rhythm, right? When this rhythm is lost, then that is called as the arrhythm. That is the abnormal rhythm. Abnormal rhythm. How will you identify it? In two ways. One, ECG. But will you be straight away going for the ECG? Not really. You need to know certain symptoms. Correct? Certain symptoms. That is what is happening. Either the patient is getting unconscious or patient is going into hypotension. That means his blood pressure is going down. So in that case, this thing should happen. So what would really happen is that when you anticipate arrhythmia, you will be going for the ECG, and in the ECG, you'll be able to see those things. Because see, we'll be learning things individually. When I give you one ECG randomly, you'll find that what exactly am I supposed to see? So we'll be having one session on that, but it would be at the end. So here ECG, symptoms, and certain things which we'll be discussing today, which you have to anticipate. Patient might not say, but you need to anticipate. And in this, one of the very important things is, say, for example, we'll be learning the heart block, atrioventricular block. Now, there are three types: type 1, type 2, type 3, right? In type 2 also, there will be two types. We'll see all those things. But one of the very important drug, say atropine, which is commonly used, but if it is given in type 2 Mbbs, so then it may trigger the type 3, and in type 3, the chances of death are very high. So one drug which is a lifesaver, but in case if you make a mistake in watching that ECG properly, right, it can lead to grave results. So that's the reason that arrhythmia, which is considered as a very tricky topic, actually it is like a mathematics. And you must have solved many of the theorems, correct? In theorems. So in theorem, what was the thing? Initially, you are given certain things, and finally you have to prove. But the things will go exactly in the same way. There will be specific data. That particular data you keep in mind, right? And then accordingly you implement it. So some of the facts which are physiological. Physiological means right now what is going on in you and me, right? Which is completely normal. Heart is beating. And if someone develops any abnormality, so that is what is called as the pathology. So one thing you must have understood, that when the heart is beating in its different rhythm, chances of having pathology, they are very high. Now, pathology could be that there is decrease in the blood supply, there might be some injury to the tissues, there might be some direct injury to the tissues, gunshot, stabbing, infection, heart attack, high blood pressure, low blood pressure, electrolytes imbalance. Something has happened to the brain, and brain is not sending the impulses to the heart, or vagus is overstimulated. All these things, or emotional surge up or down, all these things, they will lead to major changes into the heart. So heart is not actually really a pump. Heart is something which is far more complex and far more sophisticated as compared to a normal pump. When it is said that heart is just a pump which is pumping the blood, no, it is controlled by so many things. There is a chemical control, and there is a neural control. That is what we call it in the form of electronic control and the electric control, right? All these things is what we see. So when we say, one question which was asked is that what is the difference between heartbeat and heart rate? Very simple. Heartbeat is one beat. This is one beat. Right? When the heart beats for the one time, so one systole, one diastole is one beat. Correct? So that is heartbeat. In that heartbeat, lub dub, right? When it is said, when we'll be listening it on statho, lub dub. Right? This is how you should pronounce it, lub. So there is vibration, because these are the big valves, and when they close, so their leaflets, they vibrate. So lub, right? And those small valves, that is aortic and pulmonary, they are small, dub, right? So when there is no vibration. So that's first heart sound and the second heart sound. The combination, this entire thing, that is one heartbeat, or it is also called as the cardiac cycle. Right? It is also called as the cardiac cycle. One question which was asked is that during exercise, right, when we exercise, so then systole is shortened. Right? Systole is shortened. Correct? We said systole is shortened. So won't the diastole will be lengthened, right? Because if systole is short, then more time is available for the diastole. So the point is, no, it will also be shortened because the entire cardiac cycle has become smaller, correct? The heart, which was beating normally at 72 beats per minute per second, per minute, BPM, beats per minute, that's 72 beats per minute. That comes to, say, one complete cycle, right? So that is getting completed in what time frame? That would be, say, 72 beats per minute, so it will be, say, 1.2 seconds, right? But when it is beating at 120, so then only 0.5 seconds is available. Only 0.5 seconds, right? Because it is going, also this would be 0.8, right? This would be 0.8 seconds, right? Because 60 will be 1 second. So this will be 0.8 seconds. So 0.8 second per beat, right? That would be the thing. And over here, when it is going at a speed of 120, that would be just half a second. So in half a second, systole and diastole both are completed. They both are completed. And that's the reason that, yes, it is during the diastolic phase when heart is getting its coronary perfusion. So won't it happen like that as you exercise, as the heart rate increases, heart is getting less blood? True, if you calculate it on per cycle. But remember, when the heart was beating at 72 and now the heart is beating at 120. So in 120, though a heart is getting less blood per cycle, but because number of cycles they have increased, so that's why heart will be getting sufficient blood, right? This is how the physiology will be going. It is important that one should not go overboard. What is overboard? Overboard is that when the heart rate starts increasing, when it is said that 220 minus your age, so that gives you the maximum heart rate. Beyond this, it should not really cross, because if it crosses, then it is beyond the heart to handle that capacity. Correct. Now, this is a normal one. As you condition your heart, right now, let's say you are 220 minus 20, so that comes to 200. 200 will be your max. But let's say move forward 20 years from now. If this is like an investment, 20 years from now, so it will be 200 minus 40. So will your heart rate be maximum 180? Maximum heart rate, max heart rate? Yes, it will be, theoretically. But if you have conditioned yourself, so even at the age of 40, you take your heart rate all the way to 200, still you'll be pretty okay. No doubt. This is a risk, but yes, you can take it if your heart is that powerful. So what really matters is that how your cardiac efficiency. In order to improve the efficiency, I told you just one simple thing, not much. Zone 2 training, right? So today we won't be elaborating much on this zone 2 training, but we talked about it in depth because it is this zone 2 training where there will be maximum fat burning. At the same time, your cardiorespiratory efficiency will keep on increasing. Right? So this was in a nutshell. Coming back to this, whenever there is abnormal rhythm, right? Marathon was great, good. And the best part is, I recovered in 1 hour. After 1 hour, there was no pain, nothing, all good. I got, say, when I was in Expo, I got the call from Puja that so many students, they are waiting, and is there any lecture? I mean, I said that I'm telling since 5 sessions that Saturday it will be the off. So I'm not sure that why that message has not reached. Okay, how many of us are 22? Number is less. Anyway, so coming back to this, normal heart rate, when the heart rate is between 60 to 100, this is considered as normal, right? 60 to 100 beats per minute. This is normal heart rate. Medal, I'll show you. So 60 to 100 beats per minute, that is the normal heart rate. And it should start from SA node, because that is our primary pacemaker. Correct? Primary pacemaker. Pacemaker means who is generating the entire speed. And then the whole path goes, right? From, this part, we have talked several times about it, SA node to AV node, and there is Bachmann's bundle, correct? Bachmann's bundle, which goes to the left atrium, and the right atrium, it goes directly because SA node itself is sitting into the right atrium. From there goes the this AV node, atrioventricular node at the junction. Point to remember that this is the rest of the area, that is the fibrous capsule, so that's why it is insulated, totally insulated. Insulated means none of the signal it can really cross this and go into the ventricle. So here, AV node, that's the only window which takes us all the way to the ventricle. Right? Then there comes the bundle of His, right? And then left bundle, right bundle, and then Purkinje fibers, right? Purkinje fibers. And that's how the electric system of the heart goes, Purkinje fibers. As we are discussing the speed, so that's why we need to know it very well, that who will be the fastest. That is what is called as the conduction speed. The speed at which the signal will be passing through that particular electric tissue. Right? Electric tissue. So here, the Purkinje fibers, they will be the fastest. Purkinje fibers, they are fastest. Why they should be fastest? Because once the signal has reached to the muscular tissue of the ventricles, then why to wait? Right? The point is the blood is loaded, ventricles are filled with blood. So now the entire thing should be contracting together. So that's why these are the Purkinje fibers which takes that message. Then comes the atrial fibers, right? Atrial fibers, they are Purkinje fibers, they are the fastest. Then the atrial fibers. Then comes the ventricular fibers, right? Ventricular fibers. And the slowest one, AV node. AV node. The point to remember over here is that the AV node is the slowest. AV node is the slowest. And you know the reason why AV node is slowest. Right? Because AV node, it is like, as we saw it over here, right again, as we saw that this is the only junction, it is the only electronic window through which the signals they can pass from upper heart to the lower heart. So because of this delay, right, because it is slow, so that's why it imposes the delay. It is that delay which is actually the filling phase, right? The blood gets filled into the ventricle. So filling phase of ventricles, right? Filling phase of ventricles, which we technically call it as, yeah, that's right, Nisha, which we technically call it as a diastole, correct? So diastole, so that is when the heart is getting filled. Once it is filled, so that means that gun is loaded, preload is ready, and it will contract. And then starts the system, right? So, but it is by that time when the signal has been slowed down, right, this is where it really goes. Okay. Now, when we'll be discussing about the arrhythmia, two common things, which will be tachycardia and the bradycardia. Just increasing speed or decreasing speed. Right now, we are not talking about whether the P wave, what would be the PR interval, what would really happen to QRS complex, whether it is wide, less, all later. But starting with, first we are dealing with only the speed, correct? Only the speed. We know how to calculate that, right? So tachycardia is when the heart is beating at the rate of more than 100 beats per minute. When heart is going that. So that means you just start doing the exercise, heart will go more than 100 easily, right? You just start skipping, it will straight away go to 100. So is it arrhythmia? Technically, yes. Technically speaking, yes, it is a cardiac arrhythmia because that is not the normal range in which the heart should really be. So more than 100, definitely tachycardia. Definitely tachycardia, but we'll be calling it as more than 100. So up to 150, right? Now this is in general. Let's say you guys are roughly 20, right? Some 19, but for the sake of ease, 20. 220, 220 minus 20, 200. For you, even 160 is fine. It won't be a tachycardia because your age, because of your age. But someone who is of the age of 50, right? For him, 150, yes, that is a tachycardia, correct? Because in that case, say 220 minus 50, when it comes to 170, this is the maximum heart rate. So by the time when it reaches to 150, it is almost 90%. 90% of the maximum heart rate, which is like a danger zone, right? Person is approaching that. So that's the reason, keeping in general, these numbers are there. So more than 100 beat. So when we now it comes into the stages. So when it is 100 to 150, it is considered as normal, right? But still we need to give the name, so that's why the name given is simple tachycardia. Remember, in this simple tachycardia, all the complexes, they will be absolutely fine. They'll be completely fine. When it goes beyond this, right? Now the numbers, they are big. When 150 to 250, now this is not normal. That's why it is called as the paroxysmal tachycardia. Paroxysmal tachycardia. It can come down quite easily. But when it goes more than that, say 250 to 300, yes, human heart can really go that, even more than that. So this is what is called as the flutter. You'll appreciate that is if it goes 240, right? Then 240 means in 1 second there are 4 beats. So can the heart go full? No, heart will be just doing like this. So as it rises, after a certain time, the amount of output that will be relatively very less. And when it goes more than 350, which is very fatal, this is called as the fibrillation. Fibrillation means muscles, they are just vibrating, right? Actually, there is no output. So these are the tachycardias, right? From simple to paroxysmal to flutter and fibrillation. Right? We'll be going into depth of everyone, and in all the cases, we'll actually be watching the various ECGs as it will proceed. Bradycardia. Brady means slow down. Right? When you go to sleep, right? If you are wearing those smart watches, so then it will be showing you resting heart rate. So your resting heart rate, and during sleep it always drops. So when it is in the range, as it starts going down, right? So when it is in the range of say 40 to 60, so this is actually called as bradycardia, but it is called as the mild, and it could be normal. When it goes still low, when it is in the range of 20 to 40, so now this is tough, right? But still it is manageable. So it is called as the moderate bradycardia. Right? But when it goes less than 20, then it is severe. We'll be watching all the conditions as it comes. You should be very comfortable with 3 things for this particular topic. 1, the structure of the heart, that is from SA node to AB node. So anywhere, any query, immediately let me know. Second, you should be very thorough with that which voltage gated channel will open, what is funny current, what is slow sodium, what is fast sodium channels, what are voltage gated calcium channels. Right? We'll again revise those things, but keep that thing in mind that it has to be crystal clear. Right? I'll keep on, say, as we'll be discussing any of the condition, I'll tell you that, okay, we are using a calcium channel blocker. So the moment it comes to calcium channel blocker, that means this spike which is going, that spike is because of the fast voltage gated calcium. So if this calcium channel blocker, so that means this will be blocked. That means this spike will get slowed down. It never stops. But this spike, which is going like this against the timeline, right now it goes like this. So it has slowed down. Right. So anyway, and the third is, do remember. What I mean to say is that today's by the end of today's session, you will be master of all the types of blocks. You'll be able to identify. But then I'll ask you a few questions. Right? What I want is, बाद में पढ़ लेंगे नहीं. You have to remember it right now. Right? This is that type of topic. Okay. So this was the speed. Arrhythmias. Divide the heart into two parts. When the problem is above, right? This is the area of problem. So then, is this above the ventricle? Right? Because ventricles are here. Ventricles are here. So when the problem is above the ventricle, so very lovingly, that name is given as supraventricular. Supraventricular. Because it is above, right? Arrhythmias. Arrhythmias. So why? How can it really occur? SA node has got some problem. Right? SA node has got some problem. So that is above the ventricles. AV node has got some problem. So again, it is above, right? Buckman's bundle has got some problem. Again, it is above the ventricles. Right? So that's why when we say supraventricular arrhythmia, now it would be supraventricular tachyarrhythmia or it could be supraventricular bradyarrhythmia, right? That means they are beating at a faster rate or slower rate. Why can it really occur? Because SA node from our brain, right? That's our brain, and there is the medulla. From medulla goes the 10th cranial nerve, that is the vagus, and that vagus straight away affects the SA node. So, and vagus, yes, vagus is affected by your emotions. That's the reason. That's the reason that heart beats faster, heart beats slower, person feels it, palpitation, all those signs symptoms we'll discuss. So supraventricular arrhythmia, that means the problem is above the ventricle. That means SA node, atria, and AV node. Correct? SA node, AV node. So whenever the problem is over here, we'll collectively call it as supraventricular tachycardia or bradycardia, supraventricular arrhythmias. And when it is into the ventricles, obviously ventricular arrhythmias. Right? So that would be supraventricular arrhythmia or ventricular arrhythmia. Ventricular arrhythmia. Why we are discussing this? Because your entire treatment will be based on this. In ECG, you'll be able to see, just after 1 hour, you'll be able to crystal clear say what type of arrhythmia is, right? So here, these are the arrhythmias as per origin, right? Because you need to see things in multiple perspectives. So this part is clear, what we discussed till, right? That one, where the speed is important, so that was one of the criteria. And the second one, that is the origin from where it is happening. So that origin, that was the second point which we took into consideration. The next one. The next one is what is called as that why these things should occur. When a heart is beating very comfortably, why there are some changes. So this is what is called as the etiology behind any of the cardiac arrhythmias, right? What can go wrong, right? What and where that electric current, because the game entirely is of electric current, right? So this where, what and where this electric current can go wrong. No rocket science is needed. This is the fan, right? This is the fan. And that's the wire. This is the switch. And this is the power supply, right? Which is coming from the power stations, right? Power station. So power station, in between ELCB, LCB, right? Earth leakage circuit breaker, all those things, miniature circuit breaker, all those things, we keep it apart. We simply, right? Meters are there for calculations. All those things. Power source is coming. This is a switch. This is a switch. This is where the regulator is there. The regulator and the fan. This is the fan. Fan is not working properly. So what are the possibilities? Simply, we can say one, no power supply. Switch is faulty. Regulator is not working, right? Instead of say running at full speed, it is giving slow speed. Wires are at fault. Finally, fan is at fault. Possible? Wires are broken. Exactly. But this is hard. SA node. From this is the power source. SA node is sending low current, right? So sometimes it happens, right? While lights, etc., they dim out. This is the switch, AV node. AV node is like a switch. Power can be less, exactly. So SA node. This is our AV node, right? Vagus nerve, which is controlling the speed. So that is over there. And finally, the heart musculature. And these are all, you can say, bundle of hairs, Purkinje fibers. In short, the wires which are reaching to the terminal level. And then fan, that means it is our cardiac myocytes. These are our cardiac myocytes. But that's it. You have learned the whole arrhythmia. This would be the pattern. So let's start with first one. First one. Who is telling power station to make electricity? No one, right? They are constantly making and sending it to you. In our heart, who is telling SA node ke beta beat? No one, right? It is beating at its own pace, right? Constantly it is beating. So this functionality, it is what is called as the automaticity, right? Automaticity. No motivation is needed to keep on beating. So sometimes it suddenly increases. So this is what is called as the increased automaticity, right? Increased automaticity. Due to physiological reason, other reasons, whatever, but it has become spontaneous suddenly, right? So the heart rate would start increasing because rest of the wiring and everything is okay. So heart rate has to rise. Yes, it would rise, right? So this is where SA node is responsible, right? Increased automaticity at SA node, and that would really handle the whole thing. Now in SA node, just a small revision, right? What was really happening? So there was a resting membrane potential, and we said that yes, in this SA node, there is no motivation is needed. So no pulse is to be coming from anywhere, right? No depolarization signal will be coming to chalo beat, right? So it is self-motivated, and that's why, let's say we just draw the line over here, and this is our threshold potential. That means if this current is reached, some channels are going to open. So here comes the slow thing, right? What is this? Those leaky channels, right? Leaky channels. What the funny channels? Leaky channels. Which type of channels were they? They were sodium channels, right? So here is a cell. We are talking about SA node, right? We are talking about SA node. So in SA node, right? They come, right? So sodium is leaking. So as the sodium is leaking, right? That cell is becoming more and more positive. So it is rising, becomes positive at the level of threshold potential. That's the cell. Sodiums, they are going slowly. Cell is becoming more and more positive. And at this junction, there opens a spike. This spike is because of voltage gated, right? Whenever those who are new, when we write VG, means they are voltage gated. So these are the channels. These are the channels which will allow only calcium to pass. So that's why this is called as voltage gated calcium channels. So these voltage gated calcium channels that they open and boom, white calcium explodes in. That's why the spike. So this is because of the voltage gated calcium channel. Now think of that if I tell you, let's give this patient calcium channel blocker. Immediately it will strike in your mind, yes, calcium channel blocker. Then SA node, right? This with the, now say this is just a random number. Say 100 channels were opening, but because of the medicine, now only 50 channels are opening. So the new wave would be going like this. It will slow down, right? So see, that's what really happens. Achha. Coming back to this, and then at one point, so again, this is a number. It is that number when the voltage gated calcium channels, they say, okay, my work is over. And it is at that point when the voltage gated potassium channels they open. And as the potassium channels open, potassium, it is already present into large amount inside the cell. So they are thrown out. They are thrown out in large quantity. And when that thing happens, all the way it drops down. All the way. And then once again, over here, voltage gated potassium channels, right? These potassium channels, they close and sodium again starts entering in, right? As the sodium starts entering in, this is again, these are the leaky channels and the cycle continues. In this, you must have seen that there is no plateau because this is an electronic system. In electronic system, nothing is to be contracted, right? SA node is not contracting. SA node is an electronic system. So that's why there will be no plateau. Plateau will come when there is a cardiac activity because it is during that phase when small amount of calcium which is entering, it will trigger endoplasmic reticulum and large amount of calcium will come out and they will lead to cardiac myocyte. We'll see that, right? But remember, no plateau. In any of the conduction system, there cannot be any plateau because they don't have to contract, right? Okay, I'll take that. See what really happens in case of cardiac myocytes. Cardiac myo is muscles, right? Muscle cells, sites is muscle, heart muscle. In case of heart muscle, right? Once again, there is resting membrane potential. We'll be taking this slightly faster. Resting membrane potential. In cardiac myocyte, as compared to normal muscle, say, just consider this is SA node. So SA node is a firing station, right? But there is gap, and they are actually called as the gap junction. Gap junction. So from these gaps, actually, all those sodium and calcium, they enter. So whatever the way it enters, right? Other tissues, they were getting stimulated by the depolarization wave. And then the channels were opening, or the neurotransmitters, they were opening the channels. But over here, gap junction. In anyhow, electrolytes, right? Sodium, they came in, cell is becoming more positive. So when the gap junctions open, so over here, this is our resting membrane potential, right? Resting membrane, aram se. And then when we draw this, so this is because of gap junction. Because of gap junction, sodium enters. Right? Now this sodium, is it fast? No, it is slow. That's the difference, that it is the slow sodium, because these gap junctions, they are small. We'll be going into the depth that why it happens like that. AV node slows down to this drastic level. It is beautifully given in Guyton, right? But once you will understand, I'll draw everything, it will become very easy. At this point, when there is trigger of, right, because it gradually increases, and then there is trigger of this spike. Now this spike we are talking about the myocytes, muscles. This is because of voltage gated, not calcium, this is voltage gated sodium channels, and these are fast channels. Then it can spike, right? So this will be our TP, or the threshold potential, right? It is called as the threshold potential. So it is at this number, sodium channels they open, but at this peak, sodium channels they close. Their function is over. Now starts the entry of, here is the cell. So now starts, it is at this point, calcium channels open. So they come in, right? So when calcium channels open, but it is at that point, potassium channels also open. So potassium will start throwing things out and the calcium will start taking. So calcium is coming and potassium is going. So basically, it will be like a plateau. There is no effective electric change, right? So this is what is called as the plateau. And it is during this phase, when the contraction occurs. Because this calcium which has entered, this triggers, this is what is called as the CICR, calcium-induced calcium release. So it will go to endoplasmic reticulum. These calcium, you can say these small amount of calcium, they are like key. They will open the tala of endoplasmic reticulum, and then from endoplasmic reticulum, jail is open and all the kheti bahar, right? So, but this is what really happens, right? This is the whole mechanism, and then they are flooded. When these calcium occur, calcium is one of the important components which leads to contraction. So contraction occurs, but then after some time, these calcium channels, they will stop, right? So this slope is, in fact, it is something like this, yeah, gradual. And then over here, calcium, we are voltage gated, right? So they stop, but potassium continues and potassium will take it down all the way. And then once again, the new cycle starts, right? So this is because of the voltage gated potassium channels which are still active, right? So that's how it happens. As we are discussing this, let me introduce two new terms. For the sake of clarity, right, I am now in this, I'll not write anything, I'll just draw it. So these are the plateaus. So during these plateaus, things are getting activated. Now, when this is called as the depolarization, and this phase is called as the repolarization. Correct? This is called as the repolarization when cell is becoming negative. When the cell is becoming positive, it is called as the depolarization phase. Simple. As it is going down at this junction, suddenly there is one more contraction. Somehow those voltage gated sodium channels which were supposed to open over here, they open over here, and it gives this spike. Right? Now this is abnormal. Think of that, because this means what? Here the contraction will occur. If the contraction is going to occur, no, heart is not ready. Heart is telling, give me boss some time, right? Because I'm filling the ventricles. So can you imagine that before the ventricles are filled, again the message has come contract. I'll say, okay, have you understood till this point? This point here, the heart is contracting. Correct? Heart is contracting. Right? And over here, as it dips down, so heart is contracting. Correct? Heart is contracting. Now heart has to relax. When heart is relaxing, so over here it is into relaxation. In fact, up to this point, right, up to this point, contraction is occurring at this point, right? So that means anything before contraction, think it like it is diastole. So over here, when it is contraction, so can we say that this is systole, and then rest of the phase is diastole? Correct? And diastole is what? Diastole is filling phase. So when the heart is getting filled up with blood, chamber is getting filled up with blood, and before it can fill up, again the new contraction has started. So now this is improper filling. And when it happens into this area, that is before all the way it repolarizes. So this particular mechanism, this particular system, this one, right, I'll write it here. This is what is called as the early after depolarization. Early after depolarization. Right. It is also called as EAD. Right. So whenever you hear the word EAD, that is thinking about that heart is not yet fully relaxed. If it is not fully relaxed, that means the cardiac output would change. It would decrease. Correct? Makes sense, na? Because you are not given enough time for the heart to go for full diastole. So that's why in this case, what would happen? Preload will decrease. Correct? Preload will decrease. When the preload decreases, so that means the blood which is going out, it decreases. If it decreases, that means tissues will be getting less blood. So tissue perfusion would drop. So that means performance would drop. Now, which area is getting affected? So obviously those areas who are in high demand, those tissues which are in high demand. I mean, liver, you don't give blood to liver, liver will say no problem. Give me after half an hour. Chalega. Right? Brain, exactly. Brain would say 3 minutes, I'll start dying. Right? Brain can't survive even 3 minutes. 3 minutes is the upper limit. Right? So that's the reason such tissues, those who are extremely sensitive, and in brain, cerebrum is quite okay, but the medulla oblongata, especially where there is a respiratory center, that is most susceptible to hypoxia. Hypoxia means lack of oxygen. That is most susceptible. So if that center goes, right, if that center is knocked off, all the other systems, they are functioning fine, but the patient is breathing on ventilator. You switch off the ventilator and game over. So that's why this is so important. So this is clear. This is the first one. I'll change the color. Next, because see, these arrhythmias, they can occur anywhere. Now, so let me draw another figure. So this is our, let's say, resting membrane potential, and this one is our threshold potential, right? So we just draw it like this, and so here comes, right, the first thing which has occurred, spike this, and it has come down. Now over here, once it has crossed the threshold potential, right? So there is some electrical activity going on. Right? This is abnormal electrical activity going on. Some electrolytes are coming, going, but heart is not responding. And suddenly, there is some large amount of sodium has entered. And it has somehow, voltage has reached to threshold potential. Now, and it spikes. What was the real time? Real time was that heart was to contract over here. This was the normal time. But now this is contracting before that. This is also before the original next pulse. But this has occurred over here. So that's why this thing, it is called as the late after depolarization. Right? So here you are allowing the entire repolarization to complete. So this is what is called as the LAD. Late after depolarization and early after depolarization. Early after depolarization was occurring over here, and late depolarization is occurring at this point. Right. So these are two more terms which we need to remember. So all these things, they can occur. Right? Why can they really occur? Common is there. Drug. There are specific drug effect. So now, when you will be learning pharmacology, the moment it will come, yes, this thing will affect early after depolarization. So you will be knowing that this is what we are meaning, what we are telling. And you will agree that out of two, if you have to select one thing for patient, so will you, means God tells that दो में से एक चीज तो patient को देनी है. So will you select EAD or you will select LAD? What out of these two, what should be given to the patient if it is to be given? Or in other words, EAD is better or LAD is better. Both are abnormal, both are bad. But which one is better out of it from the patient's perspective? Which one is better? Okay, so EAD is better, one vote for EAD. Okay, I have asked what is better. Better means this patient would be comfortable. Only one answer. I mean, it is okay to be wrong. Okay, here LAD. Okay, 1-1 score is 1-1. Okay. Okay. Yeah. Correct answer is okay. So think it like. I'll not give the answer. Answer was which one is better. In EAD, heart will be better filled, or in LAD, heart will be better filled. In both of them, out of both of the cases, in which case heart will be relatively properly filled. Nothing as compared to the normal. See, over here, less time is available. Over here, at least you are getting some extra time. So heart would be better filled into LAD. Correct? So that's the reason that cardiac output will be better in LAD as compared to EAD. So one is the drug effect. Second is any sort of injury to the heart. Now that injury, it could be mechanical injury, it could be because of some surgery, because of some procedure, anything. Right? And lack of blood supply, ischemia, heart attack. Right? Ischemia is less blood is reaching, less blood. Infarction is when the damage has occurred. Less blood is reaching. So these are the two important say automaticity problems which can really occur. It could be say early or it could be late. Correct? So that's the entire explanation when the automaticity is affected. Like automaticity will be affected. Because we cannot tell our heart chal, take it to EAD. So this is how things are really happening. Now the next one is, this is what we discussed and you know it. It is what is called as the re-entry. Right? Re-entry. So normally here is the tissue, and here is the tissue. These are the two parts. So from one here it goes, from here it goes, right? And signal is going uninterrupted because they both are going at the same speed. So whatever the stimulus which will be over here, that would also be at the same time. So all good. But then there comes two mechanisms. Two concepts. This tissue is dead. This tissue is dead. Right? This tissue is dead. So this is what is called as the block. Right? It is not the coronary block. It is like tissue is dead, so tissue won't be allowing in one direction. Right? It is not. So from here, when the signal comes, right? So tissue is blocked at this point. Tissue blocks that signal. But from here, so it is going all the way, right? And it will go to proceed. But then over here in this particular area, there is no current. Otherwise, so if the current is coming from that side, so it will automatically go into what is called as the refractory phase. Refractory phase is that phase that during that phase, any amount of signal you give, it won't stimulate. Right? That is what is called as the refractory phase. So over here, so there is no pulse. So signal will go now abnormally over here. It will reach to this point. Right? Because the stimulus is on from other side, so this would be permitted and it will start moving. So once it is into this healthy zone, this signal will go and once again it will stimulate. So see, now it is moving on and on and on. Now, in this, one of the important conditions, I'll just write. What I mean to say is the circle, right? The circle, right? The circle, this whole thing. That is what is called as the impulse circle time. In what time frame? In how much time? That is what is called as the impulse circle time. In how much time the signal is just making one full circle. It is very important that it should be more than the refractory period. Refractory period. What was refractory period? Refractory period was that during that phase, any amount of signal comes, tissue won't respond. But if impulse circle time, so if this impulse circle time is more, so from here signal is coming, right? It is taking some time. By that time, the refractory period of this block is over and it will allow the signal to pass. So this is a very golden sentence. This sentence, right? It is, I mean, so many important things they are based on this. Have you understood this part? That just keep in mind, right? Impulse, right? If it is taking random number, if it is taking 2 seconds, right? And over here, this gate it remains closed. It remains closed for 1 second. Refractory period is that, right? So the tissue is contracted and now starts the refractory period. So during this phase, during this small phase, even if you give another signal, right, tissue won't contract, right? Tissue won't contract. So refractory phase, as such, there are two types. One, what is called as the absolute refractory period, and second, it is called as the relative refractory period. Absolute means any amount of signal you give, it won't work. Relative refractory period means if you give a stronger signal, then there would be some twitch. Right? But right now, just for our understanding, we just see that this gate is remaining closed for 1 second. So if we reach early, let's say our impulse time, circle time is just 0.8 seconds. So within 0.8 seconds, we reach to this door. So we'll get that door closed. Right? But what if we reach over there at 1.2 seconds? So if it is 1.2 seconds, we'll find that this door is open. Chalo, let's go again. Right? So this is the mechanism of re-entry, and this is a very important statement, that impulse circle time, that should be more than the refractory period, because by the time refractory period is over, so then the tissue is telling that yes, now give me the pulse, I'm ready to contract. Right? But when it is in refractory period, so it will close its eyes and it will say, no, I will not respond. That's the difference. Correct? So that is what is called as the re-entry. We discussed re-entry even before that also. Right? Same speed concept is the same speed. Same speed is when the healthy tissue. When the tissue is healthy, then there is no one to stop now. It is going from both the sides, right? All the signals, whatever the number of nerves are, all are going. This we discussed only for 2 pathways. In heart, there are thousands of pathways, right? Because all those fibers are going. So, which fiber is taking a turn, right? When the heart gets damaged, when there is infarction, so if there is a tissue damage, then so many extra pathways they are created. These re-entries are created, and that is what leads to repeated stimulation. So this we are trying that this is path 1, this is path 2, right? But simple. So in healthy tissues, both the paths they are going fine. This is path 1, this is path 2. Path 1 is blocked, right? Because there was some injury. So 2 came all the way, usne chakkar mara. But by the time it reached to this point, its refractory period is over, so that gate is open. So again, this goes into the rotation. So this circle, it keeps on moving and it will keep on generating extra impulses to the destination, because some will be weak, some will be strong. So randomly it will occur. So these are the mechanisms which can lead to arrhythmias. Right? Now we talk about some normal physiology. Normal physiology. In this, when we say this is normal sinus arrhythmia, a normal sinus rhythm, normal sinus rhythm. It is also called as the rhythm strip. So when things are going fine, a normal heart rate. In this, when you do the exercise, right? So in exercise, we need to increase the heart rate, right? But that is considered as abnormal, because every time we are not doing it. What is that process which is occurring constantly? Respiration, inspiration and expiration, right? So inspiration and expiration. Now here it is again, the brain, the medulla, from medulla, it is the 10th cranial nerve which is coming up, and this will be supplying to SNO. Now this 10th cranial nerve on the vagus, this nerve is parasympathetic, right? This nerve is parasympathetic. One of the very interesting question one of my friend asked, right? She said that, is it so that antibiotics, they change the mood of the person? Now this is true. Why? Here it is. This is stomach, right? Small intestines, large intestine, right? And then there are good bacteria and bad bacteria, right? It is there, their colonies are there. Now these are the bacteria which are not that good, and over here those good bacteria are present. So when you are giving antibiotics, they are not understanding anything. They are like a slaughterhouse. They just kill all these bacteria. Even good bacteria, they are also damaged. But in these good bacteria, there is one, what is called as the serotonin. This serotonin is made in GIT. It is a neurotransmitter. It is a very powerful neurotransmitter which actually handles your entire mood. So this serotonin, it is made in GIT, and it triggers the vagus nerve, and then the vagus nerve which is connected to the brain, and that will lead to so many changes into your mood, right? So yes, that is true. So that's why person becomes gloomy, udas, right? Because this vagus nerve, when this neurotransmitter is not there, then vagus is not stimulated. Vagus is parasympathetic. Parasympathetic means rest and digest, relax, aram, maja, right? So this is the parasympathetic. So when vagus is stimulated, so it will tell SA node what? Don't worry, decrease. So let the heart go slow, right? So that means parasympathetic, because of the parasympathetic activity, it will decrease the heart rate. But this vagus is coming via what route? Vagus is coming via our lungs, right? It is going through this entire mediastinum. Right? So when the lungs, when they expand and when they contract, they are constantly working. So it means when you do inspiration, right? So here is when you do inspiration, this is the vagus. It inhibits the vagus. Right? It inhibits the vagus. So during inspiration, actually you will see that the vagus, function of vagus was to decrease the heart rate. Now you are inhibiting the inhibitor. Right? You got it? You are inhibiting the inhibitor. Vagus, which was reducing the heart rate, you are telling vagus, don't speak. Vagus will not speak, the heart rate will rise. So yes, that is true that during inspiration, there is increase in heart rate. This is completely normal physiology, right? But see the variations they are occurring. And during expiration, it stimulates. When the vagus stimulates, so then it will suppress the SA node, so it will decrease the heart rate. Though this difference is very subtle, but yes, it is measurable. So this is normal. But what happens when someone's heart is transplanted? Right? When heart is transplanted, or someone is on pacemaker. So when the person heart is on transplant or pacemaker, right? Or when there is any sort of neuropathy. Neuropathy means those nerves, they are not responding. So you must have seen that diabetic patient, right? This is one of the very dangerous things, what is called as the diabetic neuropathy. One instruction which you have to tell to diabetic patient is what? Take care of your feet. Because if there is any injury, they might not know. There won't be any pain. Diabetes is considered as a silent killer because it takes away the pain. That pain, because of neuropathy, that pain sensations, they are not going higher. So and pain is one of the defense mechanism. It is good that we get pain so that we protect that area. So this diabetic neuropathy, right? Over here, vagus is not working. Vagus is not working. So there is someone who is telling the heart to decrease beta. No, it won't. Similarly, transplanted heart, right? When the heart is transplanted, heart. So basically, this is a denervated heart. So, and things are getting controlled by the pacemakers. So there are no doubt there are many other conditions, but this is what really happens. Right? So importance of vagus is this, right? You need to remember this, right? Inspiration and expiration. Now, there are conditions when the SA node starts firing. Right? So we'll call that thing as the sinus tachycardia. Right? Sinus tachycardia. When the heart is firing at a higher rate. In which condition? When someone is having fever. Right? Fever. You need to circulate the blood faster. Or when you are exercising. Right? When you exercise. So at that time, demand is more. If there is infection, so at that point, it is necessary that heart should beat faster so that the more blood and more forces, right, our forces of WBC, white blood cell, they should reach to the target for the attack, right? Thyrotoxicosis, thyroid, which is handling our basal metabolic rate, and toxicosis means there is overactivity of thyroid, so much so that it leads to everything is higher, heart rate increases, perspiration increases, blood pressure increases, everything. So these are when the SA node itself is involved and it is telling the heart to beat a fast beat. Right? Now, how do we know? On ECG, right? On ECG, if I give you the strip of ECG, you'll be able to immediately tell that what is the heart rate. Right? We said that go for R for rising, R, right? RR. See that? Entire ECG paper is in the form of those big squares, and in between there are small squares. Right? So this is what is called as the big square. Right? This is big square, and inside there are all those small squares. Correct. So at what rate paper moves? Paper, when you take the ECG, paper starts moving. Whether it is digital or it is physical, paper moves at the speed of about 1 inch. 1 inch per second. Correct. 1 inch is 2.5 centimeters. 2.5 centimeters is 25 millimeter. So this is 25 millimeter per second. This is the speed of the paper. Now today I'll be showing you. Oh, you have to add some pages. I'll just show you here. Here it is. See. Deliberately see the speed. Because this is a typical case. We need to figure out certain things. Right? So that's why this is this is not normally seen. Normally you won't be taking it. But when there is doubt, so this is the normal speed, 25 millimeter per second. But when in doubt, so it is like you want to see some action, so you will increase the speed, right? So the things will be recorded. So everything will run in slow motion so that you can frame by frame, you can see, right? This is that. When the paper is moving faster, so all the graphs, all the waves, they will be expanded so that you can easily measure in detail about what we are talking about, right? So we'll come to that. We'll learn all these ECGs. And though we have talked about it, but just a quick revision. So for the pace, that what is the heart rate, it was like just measure the distance between RR. So here it is 1R, right? Let's do it over here only. So this is the R wave, this is the R wave. Our paper is moving at a speed of 25 mm, 25 mm per second. So this is 5 mm, right? 2, 3, 4, 5. This much paper is going in 1 second, correct? 1 second, this much paper is going. So these are the big square in 1 second, 1, 2, 3, 4, 5. So 1 second, 5 boxes, 60 seconds or 1 minute, 300 boxes. So all we need to do is 300 divided by RR distance. So how much is the RR distance? So this is like 1, this is 2, this is 3, and just consider this as 4, right? So about 4, so 300 by 4, that means this is 75 beats per minute. This is the heart rate which is going on. If you want to be more accurate, then what you have to do is you have to go for those measuring small squares, right? Measure all those small squares. Every big square is having 5 small squares. So 300 into 5, so total will be 1500 squares divided by, once again, RR, but this time we'll be measuring those small squares, right? This is the normal. This is the totally normal. This was just for the explanation, right? All those abnormal conditions, so they are coming up. All of them. Sorry. So this is 1500 divided by RR. So that will be a bit more accurate, right? So that's how we just go for the calculation of heart rate on ECG. This was for all those, in case if you have missed those sessions in which we discussed these things in more detail, right, for the entire ECG. If you already know, well and good. Okay, now let me add just few pages. Will be requiring it. Please give me a minute. So that was for the calculation part. Now the way it was tachycardia, same way it can lead to bradycardia, right? It can lead to bradycardia. Brady means it slows down, right? So it slows down. When it slows down less than 60 beats per minute. In athletes, you will find that their heart rate beats at a lower pace. Or in pathologically, when there is hypothyroidism. Make sense? Because when the thyroid is more, so obviously it is taking our basal metabolic rate high, so everything is at high. This is hypo. Also in severely cold condition, which is called as the hypothermia. Right? Hypothermia. Now at this point, I'll tell you something about who is taking bath with cold water, even in winter. Who takes bath in cold water? मतलब shower चालू किया और थोड़ा हाथ डाला, right? But then भगवान का नाम लेके yes, right? And to take shower with cold water. No? Okay. Say if on ship when they say abandon the ship, when the ship sink, sometimes when the captain tells that okay, ship is now there is no part of return, abandon the ship, and then they jump out of the ship. The Titanic, right? In Titanic, they say people jumped out of that ship. In reality, many of them died instantly because the water was freezing cold. It was night. It was freezing cold, and during that cold, what it really triggers is the hypothermia. In that, the vagus nerve is overstimulated. It is what is called as the vasovagal shock. So vagus will send such a strong stimulus to SA node that SA node stops. SA node stops, right? And that is what is called as the vasovagal shock. Heart suddenly stops. So in case the smaller version of it is that cold shower, and when pehla haath dala, first water which fall. After that, you'll find that say if you develop some courage and no problem, chalo thande pani se nahana hai. So then after putting some water, and then you'll find now it is okay because body has adapted and the circulatory system has adapted. So then its effect will not be there. So these are the sudden things. Okay. One criteria which you, or one definition which you should really know is that sometimes you'll find in some ECGs, I'll show you those ECGs next time, but in that I give you that ECG, you'll say, okay, this is a case of tachycardia, right? And then just after about 4 or 5 beats, you'll say, no, this is a case of bradycardia. In same ECG, same patient. So this is what is called as the sick sinus syndrome, in which you will be getting both the things. The heart rate is beating fast and suddenly it slows down, then once again it fast. So that's why in such cases, you have to go for a rhythm strip. It is called as the rhythm strip. So those who were with me during when we discussed about the ECG. So in some of the cases, right, I showed you that all the ECG, right, they were 1, 2, 3, VR, AVL, AVF, V1, V2, V4 up to V6. And then there was on the bottom, there was one strip, let's say it was 2, and continuously, right, one full strip it was there. That was the rhythm strip. So it is in rhythm strip when the same lead is taken for a longer distance, and in such strips, you'll find that in somewhere the beat they are coming more rapidly, some they are decreased, and this thing is because of SA node. SA node is firing in very incorrect way, and that is what is called as the sick sinus syndrome. Sick sinus syndrome, right? Or the SSS, it's called a sick sinus syndrome. Okay. Any query till this point of time? How many of us are here? 23. Okay. Any query till this point of time? Okay, good. अरे हाँ ना, कोई भी, हाँ तो कोई भी प्रॉब्लम, सिर्फ 2 लोगों ने आंसर दिया, ठीक है, एनीवे What about vagal shock? Vagal shock is, see, vagus is what? Vagus is parasympathetic. You know? Parasympathetic will tell the heart to what? This is rest and digest. No need to do any of the strenuous things to slow down. That is what is called as the parasympathetic. So vagus is parasympathetic. When vagus is parasympathetic, so how it really acts on SA node? It will slow down the SA node. In other words, it has got the inhibitory effect on the SA node. So when the SA node is inhibited, that means SA node will be sending slow signals to rest of the brain and entire heart will slow down. Right? But what if this is sending so strong a signal that it blocks SA node. जोर से बोल दिया चुप, बस SA node ने बोलना ही बंद कर दिया. That is what is called as a vasovagal shock. There are several types of shock. Septicemia, this, that, right? Hemorrhagic shock, but they are all part of medicine, so we'll see that. Okay, chalo. So let's hope that only two answers are there. Anyway, I hope that things are clear. Moving on to the atria or the atrial arrhythmia. So in atrial arrhythmia, we discussed that there is one what is called as the tachycardia or the tachyarrhythmia. So when the atria is only contracting at a higher speed, why should it really occur? This is SA node. SA node is supplying direct lines to the atria. But that means this Buckman's bundle, right? Buckman's bundle, so it is a VIP line. So left atrium should eat without any problem. Buckman's side. Here also it is a direct line. So right atrium and left atrium, right? They both should work fine. But problem occurs when there are some other centers they start developing. Maybe because of infection, maybe because of some injury, maybe because of some infarction. And those signals, they are getting generated randomly and they are leading to contraction. So abnormal waves, they will start appearing. So tachycardia, because see over here, straight away, they will be affecting the left atria or right atria. Straight away. This atria is not understanding that this is my normal path. It will say anyone is coming and stimulating, so I need to contract. Right? So this is now when the heart rate is, this atrial contraction is between 125 to 250. So this is pretty high. Right? Up to 125 is normal. This is the condition which we'll be discussing later in more detail. It is atrial flutter. Now you have to think it like atrial flutter. Similarly, ventricular system will also go wrong. But atrial flutter means now the atria is contracting at 250 to 350. Right, that is flutter. And then comes the atrial. The most dangerous of all is fibrillation. Right, atrial fibrillation. So in case of atrial fibrillation, it goes more than 350. Multiple P waves they will be seen in this because see atria they are contracting, right? And in our P wave this is QRS and T. So this is because of the atrial depolarization, right? Atrial depolarization. So atrial depolarization it is occurring again and again. So we'll be watching multiple, right? Multiple abnormal P waves. Abnormal P waves. So P waves they could go like this, right? They could go like this, what is called as the P pulmonale, right? So all those things they can occur. Fibrillation and flutter, they are huge topics in themselves. We'll take a small topic now and then we'll be discussing about the complete block, right? All the three types of block next time. But we finished the foundation part today. So here it is. This is SA node and that's the AV node. from here, the entire game is between SA node and AV node. SA node and AV node. So this SA node is prime, but AV node is the only window, right? It is the only window between upper heart and the lower heart. Rest is all very properly insulated. This is a fibrous ring, so no signal can go. As we'll proceed, as we'll complete the arrhythmias, we'll go to those conditions in which signals can leak out of this also. It can. So that would be the pathology. Right? Just as a quick reminder, our AV node is the slowest. AV is slowest. Right? Because that is what leads to proper filling. Now, AV node can go wrong. Right? So if anything goes wrong, up till now we are talking about the SA node. So we are telling sinus rhythm or sinus tachycardia, that is SA node. When it comes to AV, it is called as junctional, because this is like a junction. This is like a junction. This is a junction. So the word which will be used is junctional. So it will be junctional tachycardia, junctional bradycardia. But when we say junctional, it means we are talking about AV node. So in this makes sense. Junctional tachycardia, or can we write it tachy arrhythmia and the bradyarrhythmia. Because when the AV node would be affected, so now no way it would be a normal thing. When the AV node is affected, definitely some abnormality has started. Right? Heart is behaving in some wrong way. So that's why this AV node, let's understand it. We said that AV node is slowest. Tissues, so they are tissues now. How is it so special that it goes at such a slow pace? There is one electric reason, and then one is the histological reason. The electric reason first. Electric reason. Right. This is the cell. So let's sit inside the cell. When we are inside the cell, there is resting membrane potential. This resting membrane potential is how much? Right? It is minus 60 millivolt. Right. Against someone whom we are very much jealous. And who is that? Those bundle of his Purkinje fibers. Right? Those Purkinje fibers. Purkinje fibers. So they are very fast. Right? So this is the cell of Purkinje fibers. If we are sitting inside the cell of Purkinje fibers, one major thing which we'll see, right, that its resting membrane potential is minus 90 millivolt. That one is minus 60, this is minus 90. Now go back to those graphs. See, both are electric system. Right? So there won't be any plateau. So what was that common graph? The common graph was that sodium gain, right? Thak. And then all the way down, and then the gain. So this was the sodium, leaky channels. And then there was rapid calcium channels, but voltage gated. And then there were voltage gated potassium channels. The whole game was occurring like when the calcium channels open. When the calcium channels open, calcium is positive, right? Bahar to calcium is in large quantity. So the door is open. Now tell me, those who are in Mumbai, in local train, if the compartment, platform pe to there are so many people, but if the train is empty, right, or if there are less people, then more people will be able to enter, or if the compartment is full, already log andar bhare pade, then less people will be able to enter. This is about the voltage. Right? When it is minus 90, these are the calcium which are plus. So they will be going at right, with a heavy speed. Right? With a heavy speed, they will be able to enter. relatively to this is minus 60, right? It is not as much negative as compared to minus 90. So in minus 90, they will be entering at a very high pace. Over here, they will be entering, but at a lower pace. So that's the reason that Purkinje fibers, they will be acting very rapidly because their RMP is minus 90, right? And while over there is minus 60. So minus 60 can pull calcium, but minus 90 will pull it very powerfully, right? So that's why that spike will go very rapid. This is the first thing. The second part, histologically, when we say, right? Histology. In this, we need to talk about two things. One, the size. Actually, the AV node cells, they are of small size. I always say it like if I am supposed to give someone 1,000 rupees और उसको 50 पैसे के सिक्के दो, how much time will it take? He has to actually calculate 50, 1 रुपया, 1.5 रुपया, 2 रुपया, 2.5 रुपया, right? But same thing is happening in case of AV node. Cells are so small, right? Very small cells line लगा के बैठे. And physiology is physiology. Nothing can be done, right? Nothing can be done. It said that first cell, yes, signal aaya, right? Then it will do all katha, right? And then will the gap junction will say कि चल भाई जरा सा ये sodium ले, right? And then the gap junction will pass on to next cell, pass on to next cell, pass on to next cell, and it happens. Small cells, so they slow down the speed. Small cells, and on top of it, less gap junctions. Two things. So एक तो small cell, right? So this is one cell, this is another cell, and in case of Purkinje fibers, the cells, they are like elongated cells, and more number of gap junctions. But obviously, so once the entry, then to dhar, right? Straight away it will reach to this point because cell is big. While over here, every time it has to do that entire katha, the cells are small. So these are the two major things. One, over here, it has got more gap junction and larger cell. In fact, it is larger longitudinal cell. So these are the two things due to which you'll find that Purkinje fibers, they react very rapidly, and our AV node, that is the slowest one, but it is good, right? Because that gives the filling time. So this is what really happens in case of, say, AV node and Purkinje fibers. Next time, we'll be starting exactly from this part. We'll just revise, in case if it is needed, we'll just revise this much. What we shall be learning is that what is called as the heart block. So in heart block, there will be type 1, there will be type 2, there will be type 3. In type 2, once again, there will be two types, what is called as the Bankim phenomena and the Hay. Right? It is called as the Bankim and the Hay phenomena. And how to differentiate and how to differentiate it clinically from ECG perspective, and what are the precautions which are to be taken, and how to see the ECG, so that within split second you know that what you are dealing with, correct? But yes, in order to understand this, for those who have not really gone through the ECG part, if not much, at least go through the basic concepts of ECG. That would be sufficient. So basic concepts of ECG, that means when the current comes towards the electrode, then it gives the positive refraction. When the current goes away from the electrode, so it gives negative refraction. And then what is, just this much you should really know, that what is lead 1, lead 2, lead 3, then AVR, AVL, and AVF, and V1 to V6. These are the 12 leads. Because on that day, we won't be able to discuss that what is Einthoven's triangle, and because otherwise we won't be able to finish. So we want to really dive deep into these topics. So in case if you are not very clear, this and Einthoven's triangle, bus. This much you just go through. Anyone who has not attended the ECG part, the previous ECG, you're there on, they are there. So you can just go through that. Yeah, on my YouTube channel also it is present in detail. In detail it is there. So thank you so much. And day after tomorrow we'll meet and we'll move on to the second session of this cardiac arrhythmias. This week we'll be completing the cardiac arrhythmias because after that we'll be going for still higher. Hi, if you attended even if you attended the first half of the ECGs, then also you'll be comfortable. No problems. Want to see the medal? Wait, I'll just get it. That's the medal. All right. And on 19th of January, I'm coming to Mumbai to take part in that Tata Mumbai Marathon. Yeah, 2025. Okay, so thank you so much. See you soon. Or till then you've been charged. We'll plan, we'll meet. So take care and see you next time. Surely.